What's the level of severity of the the cerebrovascular incidents that you mentioned?
It ranges from silent. We have a fair number of individuals who have silent strokes that are caught just on routine MRIs. And we have patients who walk into our ER with, limb paralysis. We have a small proportion, while the majority of CNS incidents are ischemic, there is a small incidence of patients that have hemorrhagic incidents that tend to be a little bit more severe in their presentation.
And infectious disease complications?
Absolutely. So we see a lot of infectious. Well, I should take that back. We used to see a lot of infectious disease complications, and the initiation of penicillin prophylaxis in the individuals who are less than 5 really altered that dynamic. We hardly ever see fulminant sepsis in individuals who have been on antibiotic prophylaxis and have been vaccinated appropriately against the encapsulated organisms that the spleen should be fighting but can't in sickle cell disease because of their hyposplenic or poor spleen function.
Do you think the use of prophylactic antibiotics is maximized in this patient population, especially the pediatric population?
I think we do a reasonable job of ensuring that our patients under 5 remain on antibiotics. It really helps to have parents that are sort of engaged and involved in the care of these individuals. Is there room for improvement? Absolutely. Is our adherence 100%? Probably not.
And I understand it's a CMS quality measure, but it's voluntary reporting, so I'm not sure we know what we're doing, other than in the individual practices.
That's true.
Yeah,
that's very true.
I think also as you get into these strokes are happening in children, young adolescents.
Absolutely.
Not when you're 40.
That's correct.
So if the ability actually to predict, right, who is at high risk of a stroke, and are they seeking that they have access to the right care,
Sure.
so that you can have transcranial Dopplers.
Absolutely.
And because then there is something we can do to prevent the stroke. I mean, that's really a huge hallmark.
That's right, absolutely. The biomarker, this imaging biomarker of transcranial Doppler has been just huge in reducing our our stroke, basically, incidence. We're able to stratify quickly who's at risk for a stroke. The issue becomes getting patients to the transcranial Doppler appointment, getting patients to be compliant still is an issue for us.
A lot of the things we've been talking about so far are sort of acute complications, right? A vaso-occlusive crisis, pain from that, or pain related to the inflammation, the cerebrovascular incidents, and so on. But there's a chronic component to this, right? So how do those progress on and evolve?
The major chronic complication of sickle cell disease is chronic pain. And essentially what we're seeing there is a component of neuropathic pain that doesn't respond tremendously well to opioids. But we don't really have anything better to treat it with at this point in time. A large number of patients deal with chronic neuropathic pain. It's an under-recognized entity by providers. It's difficult to test for, and even more difficult to treat. On top of that, with the endothelial dysfunction that we discussed earlier, patients tend to run into chronic issues of pulmonary hypertension, which is a very prolific problem in our aging sickle cell population. That's quite difficult to manage at times. And then the last one that I want to touch on is an entity called avascular necrosis, which tends to occur in the hip and shoulder joints of individuals with sickle cell disease, particularly in the subtype SC, where we basically have sickling occurring in the small vessels of these joint spaces. That tends to cause quite a bit of decrease in the quality of life of these patients.
So as I hear all of that and think about the move from the acute complications, which we've kind of touched on, to the chronic, I have a couple of well-known payers here who are very thoughtful about this. How are those impacting your work, but also how that goes upstream to the employers or the government as payers?
Well, as I mentioned earlier, my pediatric or my child population represents about $22 million spend for about 3,000 patients. 4,000 patients, that number goes up to almost $41 million. So as that disease progresses and we're not having modalities that can treat the upstream progression of this disease, preventing it from getting worse as they age, then we're going to see higher cost.
It also appears that, we're focused on symptoms, and yet the opportunity is to focus on disease-modifying therapies. Right. And so as payers, many times what we end up seeing is the ER visits, the hospitalizations, the cycling through the ER, which then brings case management usually into the fold, because now these patients are high cost. And hopefully the ability to connect them to centers of excellence, to connect them to specialists, to deal with the social determinants, including transportation or housing. There's also sometimes a behavioral health component to this that maybe you can speak to, that obviously has an impact on the way these patients function, their attitudes towards certain treatments, and even patient accountability to care for themselves. So this all bubbles up into, even bigger issues around compliance, adherence, follow-up, and even access to care in some of the rural areas.
Absolutely. I want to just add on to that. That's very well said. Sickle cell disease, we focus, you're right, on the biology. But truly, through and through, this is a biopsychosocial disease. And unless you're addressing all three components of this disease, you're not going to make any real improvement.
I want to come back to that in just 1 second, but I did want to ask you a follow-up before we go there, which is this a disease state where you've had other payers or employers be addressing, the costs of it, and what are we doing about it?
I would say employers, not so much, because I think we have to remember that as we look at commercial versus Medicaid versus Medicare, a lot of these patients may not make it to ripe old age of 65. Mm-hmm. Some of them may be duals. But this disproportionately affects Medicaid because of the disability component, which can happen very early on. And so I don't think it's top of mind for employers. When you run the data on the commercial side, usually sickle cell disease is not in your top 10, probably not even in your top 20. But in Medicaid, it certainly is.